Look around. Have you ever heard of cardiovascular disease before? If not, I bet you are the luckiest person. But what about your friends and family? Unfortunately, it's one of the heaviest burdens our modern society carries. And these are not even my words. For example, that chart by our world data shows that cardiovascular diseases have always been the leading cause of death worldwide, and that number has increased 1.5 times over the past 30 years. Generally, the World Heart Federation reports the same and also adds it represents 1/3 of all global deaths with ischemic heart disease and stroke in the first place. But what about the second graph? Why does it show that the death rate is decreasing? How to understand that? Actually, it's called age standardization, and it can be helpful when comparing rates of health outcomes between populations. Since age structure is different between countries and in the same country over time, this adjustment allows to see how mortality and morbidity vary without age differences. And the World Health Organization sets that standard population for 25 years, but it does not reflect the current situation at all. So, what's about the main driving factor here? And as I have already alluded to, it's age. The older you get, the more likely you are to develop abnormalities called lesions in walls of arteries, which are, in fact, inevitable. If you don't trust me, trust Wikipedia. But jokes aside, atherosclerosis is ubiquitous if you are over 65 years old. Okay, I suppose you want to know what to do about it. Overall, serum cholesterol is measured to understand whether we are at risk or not. But why has it become our prime suspect? I suppose just because it's found in plaques, along with other lipids, calcium, and fibrous connective tissue. But what is it? Essentially, it's just an organic molecule, which I love to call a honeycomb in the world of lipids. By the way, it has that fancy functional group, which will be discussed a bit later. So we need it, don't we? Just imagine that every cell of your organism has its own membrane, aka lipid bilayer, which protects its contents, and it primarily consists of phospholipids. These guys are amphiphiles, meaning they wield both hydrophilic or polar and lipophilic or non-polar moieties. And I adore the way they wiggle. Let's continue. As you recall, cholesterol has its own hydrophilic head, so despite its lipophilic nature, it possesses amphiphilic properties as well, which makes it crucial to all cell membranes. In fact, cholesterol is so vital that every cell in your body can produce it, thus it doesn't require its delivery. However, it's a key component in steroid hormones like cortisol and other compounds like vitamin D. Our liver synthesizes about 20% of it, and the remaining 80% is synthesized by other cells. But there is a truly fragile piece called homeostasis, because excess cholesterol will crystallize and cause cellular death. So the number one way to get rid of it is to convert it into bile acids and then excrete them in the stool. But notice, cholesterol exists in two forms, anesterified one and cholesterol ester. But the liver is only able to send anesterified cholesterol. Thus, about 85% of it in your gut is actually of endogenous origin. Moreover, much of the cholesterol we ingest from food, or exogenous one, cannot be absorbed because of the bulky side chain it carries. But if that happens, it competes for absorption with a vastly larger amount of anesterified one supplied by the biliary route. To sum up, it has a very little impact on your serum levels, so eat it and enjoy it. Okay, but how does it move within your body? Since blood is an aqueous solution with a bunch of particles in it, it is necessary for the molecule to be hydrophilic to be able to swim there. But unluckily, cholesterol loses its fancy head if esterified and becomes extremely lipophilic. So there are some vessels called lipoproteins which are designed to commute it from one place to another. In fact, it's just a passenger on board along with other lipids or triglycerides. And that's exactly where the density nuances kick in. The more the triglyceride content, the less the density, because these guys have 3 fatty acid chains, which makes them too bulky. But every ship has its captain, called apoprotein, which steers the vessel towards the destination. Once bound to lipids, it's called apolipoprotein, and it comes in different shapes and sizes, which determine its class. Let me focus on 2 main ones, A1 and B. The A-class designation stems from the fact that it migrates with alpha proteins in an electrophoretic field. Conversely, the B-class designation is associated with beta proteins. That's why the pattern of movement is drastically different. Virtually all ApoB in our body is found on low-density lipoprotein, or LDL, while most ApoA1 is on high-density, or HDL. Going a step further, there is only one ApoB molecule per particle. Just remember it, it'll come in handy. Trust me. So we can divide lipoproteins into 3 key groups, depending on their mobility. Chylomicrons transport lipids absorbed from the intestine to adipose or fat, cardiac and skeletal muscle tissue. On the other hand, high-density lipoproteins deliver cholesterol to steroidogenic tissues and adipocytes, again, fat cells, which are used as a storage organ for cholesterol ester. Finally, the major function of the very low-density lipoproteins is to carry energy, or triglycerides. Their cholesterol is ultimately trafficked back to the liver. And with all that being said, let's get straight into it. These poor energy carriers have an inevitable fate because they abide by the only rule: the less you have, the more likely you are to sink. Wait, I'll explain that. The liver exports very low-density lipoproteins, which, after chylomicrons, are the largest. VLDL particles give up some of their triglycerides in the form of free fatty acids and shrink as they also release surface phospholipids. Once a certain size or buoyancy is reached, it is called a VLDL remnant and ultimately an intermediate density lipoprotein. Some of the ideal particles undergo continued lipolysis to reduce in size and become the infamous low-density lipoproteins. However, under certain circumstances, the LDL will penetrate and deliver its cholesterol load to the artery walls. And this happens due to the vascular structure. The inner coat of an artery or vein is called the tunica intima, and its endothelium layer is in direct contact with the blood flow. Hence, these small violators tend to sneak into the subendothelial space. They retain there because of the proteoglycans, specific compounds which act like cement, keeping the LDL particles and their cholesterol content. That's the clear sign for inflammation, and the special cells called macrophages are deployed just to get rid of them. However, they actually wreak havoc on your artery walls. As they devour lipoproteins, they get bigger, forming the foam cells, thus expanding the subendothelial space. Subsequently, more and more ApoB-containing particles enter there and continue to be retained due to the existing room being created. As this process continues, an even more advanced form of immune response mediated by T cells leads to further retention and destruction of the artery wall. Eventually, not only does the lumen of the artery narrow, but a fibrous cap develops and plaques take form. It's called diffuse intimal thickening, simply DID, and it's strongly connected with thrombosis as the plaque ruptures. This leads to ischemia and ultimately myocardial infarction and stroke. Whew. Finally, it's been a long way, but we've got to the juiciest part. So, I'm ready to introduce you to the causes. And as we have already discussed, the more particles enter the subendothelial space, the more advanced form of immune response occurs. Therefore, the primary driver of atherosclerosis is the number of ApoB trafficking lipoproteins in circulation, of which LDL particles are the vast majority. But what's about the size? Does it actually matter? And that's the most interesting question. Despite the fact Peter Attia is the person who inspired me and whose series of articles I consider underlying, I'm gonna look at this topic from another point of view. The whole buzz started with this figure taken from the Quebec cardiovascular study. It divides LDL particles into small and big ones and shows when the amount of them is low, the size does not matter. But the more of them, the greater the risk smaller LDL particles seems to carry. But let's look at the extract from the same article, which states the size as a continuous variable did not contribute to the risk of ischemic heart disease. But what does it mean, continuous? I think it's better to start with the term variable. In fact, it's just a set of constants. Being discrete implies that each value separates the whole range into different intervals, for example, large and small. They form a discontinuous sequence, meaning they are isolated from each other in a certain sense. But if we introduce the continuous one, the possible values will be infinite between a range. Consequently, there will be no isolated points. That's why we can treat it like a constant, because there is only one category. Apparently, when this same analysis is done using LDL size as the continuous variable, its influence goes away and only number matters. Going one step further, we could have get rid of any ranges at all and merge all the ApoB-containing particles like VLDL, IDL, and LDL into the only interval. In that case, they will look the same, but they are, of course, not. In the following post, Peter discusses the figure from the Journal of Clinical Lipidology, which makes clear that the size and the number are in inverse proportion to each other relative to the risk. But let's look at this data parsed out another way. That graph shows 4 possible groups depending on the same values. You can see that the amount of particles is the key driving factor, but we can specify the risk of cardiovascular events depending on the size. And that's clear, the more the cholesterol content, the less the chances of the negative outcome. And it's confirmed by another study followed a Framingham offspring cohort of about 2,500 patients over 15 years. As a result, your serum low-density lipoprotein cholesterol level is negatively associated with atherosclerosis, irrespective of the particles amount. Quite a bold statement, I'd say so. I understand, I may be mistaken, but I always try to change for the better. So, let's get started.